Li Xinyan. She's the director of ultrasound department of Maternal and Child Health Hospital of Guangxi, Republic of China. Professor Li will give us a speech. Thank you.
Good afternoon, everyone. It's my pleasure to have the opportunity to address such a distinguished audience. My name is Li Xinyan, and I worked in the Maternity and Child Health Care of Guangxi Zhang Autonomous Region in People's Republic of China. The title of my lecture is Ultrasound Integrated Monitoring of Cesarean Scar Pregnancy to Placenta Implantation. Part 1, Cesarean Scar Pregnancy. Cesarean scar pregnancy refers to a rare ectopic pregnancy in which the gestational sac implanted in the scar of cesarean section. The incidence rate is about 1 versus 2,000. CSP was previously thought to be rare, but the incidence has increased significantly in recent years due to the above factors. The main risk factors of CSP is the cesarean section. And China is one of the countries with the highest cesarean section rate in the world. The clinical manifestation of CSP is that the patient had a history of cesarean section, menopause, HCG positive, and may be accompanied by lower abdominal pain and vaginal bleeding. The diagnosis of CSP depends on the clinical history, laparoscopy, hysteroscopy, CT, MRI, and ultrasound. However, the gold standard for CSP diagnosis is the pathological examination, but it's not physical in the clinical practice. So the transabdominal and transvaginal ultrasound is the preferred examination method with high sensitivity and is often regarded as the gold standard for diagnosis. The ultrasonic diagnosis criteria of CSP is as follows. It should be noted that not all CSP have typical ultrasonic manifestations. There is no pregnancy in the uterine cavity, but some of the pregnancy must be located in the scar. The CSP need the differential diagnosis with the following disease: the cervical pregnancy, inevitable abortion, pregnancy in the lower anterior wall of the uterus. The observation content of CSP in early pregnancy. The relationship between the lower edge of the GS and the uterine isthmus incision, whether convex, the blood flow, and radial myometrium thickness. The observation content of CSP after 9 weeks of pregnancy. The placenta position, the relationship between the placenta and the cervix and the incision. The degree of outward expansion and growth, blood flow, radial myometrium thickness. Let me introduce the application of multiple imaging techniques in the diagnosis and prognosis evaluation of CSP. two-dimensional and color Doppler ultrasound. The accuracy of experienced sonographers in the diagnosis of CSP is about 80 to 85%. Three-dimensional ultrasound is an important supplement to traditional two-dimensional ultrasound. Three-dimensional energy ultrasound is not affected by blood flow velocity and incident angle. It can display low velocity blood flow and can also study and analyze the blood flow signal in the sensing area. The contrast-enhanced ultrasound. The ultrasound contrast agent first reaches the implantation site of the gestational sac with the blood flow so that the plantation site is first strengthened. And CEUS are conductive to this feature and can accurately determine the implantation site. The MRI is of great value for the diagnosis and treatment of CSP. However, it's expensive, complicated, and time-consuming, so it can be performed selectively. CT is another useful method, but the disadvantage is radiation. Let me introduce the ultrasonic classification of CSP. According to the growth pattern and development of CSP in uterine sky, the CSP can be divided into different types. However, there is no recognized best CSP classification method. In 2000, Weil first divided CSP into two types, endogenous CSP and exogenous CSP, according to the depth of GS planted in the skull of cesarean scar. In China, the 2012 consensus adopted this classification method. However, it also has many shortcomings, such as no clear objective indicators, and simple dichotomous method is not suitable for all CSP. The author, Gary G., used the ultrasound crossover site to classify the CSP. In China, the expert consensus on the diagnosis and treatment of uterine scar pregnancy after cesarean section in 2016. The main basis for CSP classification is the thickness of the myometrium at the scar and the degree of protrusion of the GS. If the gestational sac is partially or mostly located in the uterine cavity, and the residual myometrium thickness is more than 3 millimeters, it is type 1. The risk of this type is relatively low, and ultrasound-guided curettage is often selected. If the residual myometrium thickness is less than 3 millimeters, it is type 2. This type adopts ultrasound-guided curettage, uterine artery embolization, and curettage, vaginal and abdominal surgery. Type 3. If the gestational sac was convex to the bladder and the residual myometrium between the GS and the bladder was significantly thinner or missing, It was type 3. This type is of high risk, tends to UAE, combined MTX and curettage or resection of the lesion. This is a special manifestation of CSP in type 3, that is mass type. It is characterized by a mixed mass located in the scar, which bows towards the bladder, and the myometrium is significantly thinner or even missing. The mass type is more common in CSP after abortion, caused by residual pregnancy and bleeding. Part 2, placenta implantation. The CSP is an early stage of placenta implantation. It is a continuous disease process and have a common pathological basis. The placenta implantation is the abnormal invasion of placental villi into the myometrium. According to the degree of implantation, there are 3 types: placenta accreta, placenta increta, and placenta percreta. The ultrasound size of placental implantation in early pregnancy. The position of the GS is low, embedded in the scar, and the residual myometrium is irregular and thinner. CDFI showed the abundant blood flow. With the increase of gestational age, the location of the GS implantation is difficult to evaluate. The local disappearance of the subplacental muscular layer and the increase of subplacental blood vessels, the placental leucini, are visible. This is the ultrasonic feature of placenta implantation in middle and late pregnancy. This is the picture of the placenta implantation. Let me introduce the placenta implantation ultrasound score system. According to the specific ultrasound manifestation of the placenta accreta, combined with medical history, many institutions have developed a variety of scoring criteria. In China at present, the PAS scoring system proposed by Peking University Third Hospital in 2016 is widely used. From 2018, our hospital began to classify CSP according to the 2016 expert consensus and achieved good results. Part 3, cases sharing. Case 1, 22 years old woman with history of cesarean section. At 6 weeks of gestation, we classify as scar pregnancy type 1. The pregnancy continued at 12 weeks, and we find that the placenta previous status. The placental implantation was shown at 23 and 32 weeks, and the ultrasound score was 9 points. The discharge diagnosis showed that the placenta percreta and the post-operative hemorrhage is about 2,300 milliliter. Case 2, 24 years old woman with history of cesarean section. At gestational 7 weeks, the lower part of the gestational sac is located in the lower part of the uterus. Part of it conveys into the myometrium, and the myometrium thickness is about 5 millimeters. So we classified as type 1 CSP. At 12 weeks of gestation, the placenta completely covers the cervical internal orifice. At 23 and 32 weeks, we can see that the pictures show the placenta implantation features. At 36 weeks, the ultrasound and MRI show the placental implantation, and the plantation ultrasound scored 9 points. The discharge diagnosis showed that the placenta accreta and the post-operative hemorrhage is about 1,200 millimeters. Case 3, a 27-year-old woman with 2 cesarean sections. At pregnancy 6 weeks, we classified it as a CSP type 2. The pregnancy continued at 8 gestational weeks. At 12 weeks, from the picture, we can see some early placenta accrete ultrasound features. At 18 weeks, 30 weeks, and 31 weeks, and 32 weeks, we can see the placenta accreta and the myometrium is thinner and thinner, and the ultrasound score is about 8. The discharge diagnosis is complete placenta previa and accreta with bleeding 3,000 millimeters. Summary. Early misdiagnosis of CSP can lead to serious complications of late pregnancy, and excessive diagnosis of CSP can lead to the loss of survival opportunities. The treatment options for CSP are diversified. All the team should have rich experience in observation and treatment of CSP to placenta implantation. The ultrasound department should improve the understanding of CSP and placenta implantation and carry out standardized operation measurement training. The purpose of this project is not economic benefits, but to provide human services to patients and improve social benefits. That's all for my speech. Thank you very much.
Thank you, Professor Li. Professor Li pointed out the ultrasound is important in the diagnose and monitor of CSP. Combined 2 ultrasound methods should be the first choice for the diagnosis of CSP. And the clinical significance of early actually diagnosis and risk assessment, as well as the relevant experience of treatment and rescue are discussed. Professor Li also hoped that ultrasound department will continue to improve the understanding of scar, pregnancy, and placenta transportation and carry out standardized operation, measurement, and training. Thank you.